Hello, everyone, and welcome to today's webinar, To See or Not A1c, HbA1c Utilization in Light of Recent Lab Guidelines. I'm Christina Jewell of Lab Roots, and I'll be your moderator for today's event. Today's educational web seminar is presented by Lab Roots and brought to you by Sebia. To learn more about our sponsor, please visit sebia.com. Now, we encourage you to participate today by submitting as many questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Submit. We will answer as many of your questions as we have time for at the end of the presentation. I would now like to welcome our speaker, Dr. Matthew C. Wagner, Senior Scientific Affairs Specialist at Sebia. For a complete biography on Dr. Wagner, please visit the Biography tab at the left of your screen. Dr. Wagner, welcome. You may now begin your presentation.
Hello, thank you for that introduction. As was stated, my name is Dr. Matthew C. Wagner, and today we are going to be speaking on the topic of hemoglobin A1c utilization in the light of recent lab guidelines. To add a bit of a Shakespearean air to it, we're titling this particular presentation To See or Not A1c. A bit of a disclaimer just to start. The following content is provided by Sebia. We do not represent any of the other organizations mentioned in this slide deck, not the ADLM, ADA, NGSP, and the following is an interpretation of the original documents. Please refer to the original source for the most accurate and complete information. What topic of our presentation today is the standards of care in diabetes, and these are guidelines and recommendations which cover all aspects of diagnosis, monitoring, and treatment of diabetes mellitus. These guidelines and recommendations undergo a thorough update once every 10 years or so, and they have recently been updated in the 2023 release. Prior to that, the previous full release was in 2011. Between the release of those two versions, of course, the Professional Practice Committee did provide updates and notices in order to keep the standards in alignment with current research and current standards. But the 2023 release does represent a full republication of all of the recommendations, and as such, it's important for us to take a good long look at it, especially since the 2011 version, there have been significant updates impacting the hemoglobin A1c testing environment, specifically the introduction of two new methodologies, those being capillary electrophoresis and enzymatic measurement of hemoglobin A1c, as well as updates to methodologies already available, the next generation immunoassay techniques. We are specifically going to be focusing on hemoglobin A1c in this presentation. This is an analyte which is very familiar to the clinical laboratory. But as we approach hemoglobin A1c, it's important to keep a few things in perspective. The clinical laboratory is not just a body in the hospital which produces a number, hands it over to the doctor, and never thinks about it again. The role of the clinical laboratory is epitomized in the guaranteeing of reported result accuracy. This is making sure that the instruments are reporting accurately, making sure there isn't something quirky or strange about particular samples that raise red flags, things like that. And this is done to ensure the highest standard of care for diabetic patients, to ensure early diagnosis when patients first become diabetic, to offer an accurate assessment of the glycemic or diabetic state of patient populations, and of course to provide guidance in the long-term treatment of patients who do have diabetes. So hemoglobin A1c is not just a number that is produced by the lab. It is an analyte, and the testing of that analyte needs to be carefully understood. So let's jump right into it in looking at these recommendations and guidelines. We're going to be comparing the version from 2011 to the version that was most recently released in 2023. Now, as you might expect, and fortunately for everyone involved, A lot of these standards and recommendations are pretty much the same between the two versions. For example, most essentially, we're not changing the diabetic diagnostic range. We're still looking at that 6.5% hemoglobin A1c as being diagnostic for diabetes mellitus. This is well established in the literature, well understood, and it's not at all surprising that there's no change to that particular aspect. What is interesting, however, and what is a little bit of an update, is the sort of cementing of the pre-diabetes state within these recommendations. Now, the range of 5.7 to 6.4% hemoglobin A1c has been known in the 2011 version and has been known as a category of patients who are at risk, who are likely to move on to full diabetes. But it wasn't cemented into the recommendations in the old version, whereas here it is now up front and center, making clear for everybody that this is a diabetic or pre-diabetic state that needs to be watched out for in these patients, right there, up there in the recommendations. There's also, interestingly, sort of a continuing worry about the status of point-of-care hemoglobin A1c assays. In the old version of the recommendations, the point-of-care hemoglobin A1c assays were said to be not sufficiently accurate to use for the diagnosis of diabetes. This sort of worry is carried forward into the 2023 version, in which we're told that point-of-care hemoglobin A1c testing for diabetes screening and diagnosis should be restricted to CLIA-certified laboratories of moderate complexity or higher. And that kind of removes that point of care testing from the point of care environment. It moves it into the high complexity laboratory setting. So there is still a bit of worry, a bit of caution surrounding point of care hemoglobin A1c techniques in these recommendations and guidelines, and that should be kept in mind for any laboratory that is considering the point of care use. Another set of standards which remain largely unchanged, unsurprisingly, is that the recommendations still state that any testing, any measurement of hemoglobin A1c should be done with an NGSP certified technique that is traceable to the DCCT study. The DCCT study, of course, was the initial study which linked hemoglobin A1c percents to the microvascular and macrovascular complications, which are typical of the diabetic state. We're talking about retinopathies, neuropathies, things like that. So the DCCT study linked those specifically to hemoglobin A1c percent. So of course we need to make sure that our testing is in alignment with that study. It's also unsurprising that the recommendations and standards state that anyone who is doing hemoglobin A1c testing should be participating in proficiency testing. Most familiar is probably CAP testing, but of course there are many other options out there. It's also stated that the testing schedule has not been changed between the 2011 version or the 2023 version. Patients who have diagnosed as diabetic should be measured routinely every 3 months until they achieve their targets, at which point measured no less than twice a year. However, within this last recommendation, there is one very small change in verbiage. It is stated in the 2011 standards that hemoglobin A1c testing should be performed at least biannually in all patients. Whereas in the 2023 version, it states that in most individuals with diabetes, hemoglobin A1c should be measured. This is a very subtle change, but it is one that is enlightening for the direction of some of the changes which are seen between the old version and the new version as we move on to other recommendations. This is a significant change. What has changed? That in the old version of the standards, they stated that all patients should be measured by A1c, whereas in the new version, it says that most patients should be measured by A1c. Well, this is due to an increased focus in the guidelines on a particular aspect which was present in the 2011 standards, but which is much more upfront and much more focused in on in the new version of the recommendations and guidelines. In the recommendations and guidelines, it is stated that clinical laboratories, not just clinicians, not just the patient's direct sitting across from them at the table doctor, but clinical laboratories need to be aware of interferences in particular patient populations that preclude the use of hemoglobin A1c in diagnosis. And the labs also have to be aware that there are disorders which affect red blood cell turnover, which may cause spurious test results. In the case of these patients, you cannot use hemoglobin A1c. Instead, you should be using glucose testing as an alternate, and later in the recommendations, we'll see that they also speak to glycated albumin or fructosamine. Well, this is a bit worrying. What exactly are these interferences that we're talking about? What are these interferences we need to be aware of in our patient population? Well, specifically in the recommendations, they speak to hemoglobinopathies. And speaking to hemoglobinopathies brings us to the most drastic change in the recommendations, the ones for which there is no recommendation in the previous 2011 version, but in the 2023 version, there is a very important change. And that is the statement in one of the recommendations that hemoglobin A1c cannot be measured and should not be reported in individuals who do not have hemoglobin A. The clinical lab has to know that you do not measure or report hemoglobin A1c in patients who do not have hemoglobin A. In those patients, use fructosamine or glycated albumin as an alternative. Now, this is a significant change. We're talking about patients who don't have hemoglobin A. What kind of a patient can we be talking about that they don't have hemoglobin? Well, of course, they do have hemoglobin, they just have a different kind of hemoglobin. We're talking about patients with hemoglobin SS disease or hemoglobin EE disease. We're talking about sickle cell anemia. We're talking about those patients who, through the inherited hemoglobinopathies, have no hemoglobin A present. So when we talk about these patients who have no hemoglobin A and why we can't measure hemoglobin A1c in them, we have to go back to the actual definition of what is hemoglobin A1c. Hemoglobin A1c is the proportion of hemoglobin A that is irreversibly glycated at the N-terminal valine of the beta chains. So if we look at a regular patient, a patient who does not have any hemoglobin variants in their system, the vast majority of their hemoglobin is going to be hemoglobin A. And we can take that hemoglobin A and divide it up into two portions. Hemoglobin A0, the non-glycated form, and hemoglobin A1, which is the glycated form. But it's not just the glycated form we want. It is the glycated form that has the glucose adhered to hemoglobin A at the N-terminal valine of the beta chains. We're not talking about the pyruvate joined hemoglobin. We're not talking about the fructose glycated fraction. We're talking just about the glucose adhered at the N-terminal valine of the beta chains. And that is our definition of hemoglobin A1c. So in these normal patients where the vast majority of their blood is hemoglobin A, they have that hemoglobin A in their circulation with the glucose in their plasma, and it's going to form hemoglobin A1c. But if we're talking about a patient who has, for example, doubly inherited hemoglobin S, they have no hemoglobin A. They have this alternate variant hemoglobin in their circulation. And that hemoglobin is in circulation with the glucose. And it's not going to form hemoglobin A1c, it's going to form hemoglobin S1c. Similarly, individuals from Southeast Asia we frequently encounter have inherited homozygous hemoglobin E. In those patients, they're just going to be producing hemoglobin E1c, not the A1c we're targeting. And even patients who happen to have two different beta variants, such as SC disease or sickle C disease, those patients are still not producing any A1c. They're producing a mix of the glycated form of those variants, S1c and C1c. Now, the hemoglobin A1c test measures the percent of hemoglobin A that is glycated, which provides us an estimate of the average blood glucose level over the past 2 or 3 months. In these patients who don't have hemoglobin A, they have hemoglobin. They have the variant hemoglobin. And this variant hemoglobin is glycated in this environment just like hemoglobin A. Why can't we just measure this S1c or E1c percent instead? Well, strictly speaking, according to the recommendations, because that is not the analyte that we say we're measuring. So there are several reasons which recommend against measurement of those alternate analytes. First, in direct adherence to the guidelines. Second, due to analytical targeting, which is different between the different methods that measure hemoglobin A1c. And third, due to biological interference caused by the disease state these patients have from inheriting those hemoglobin variants. We're going to take a little time and look at each of these points in turn. First, in direct adherence to the guidelines. In 1995, the IFCC initiated a global approach to the standardization of hemoglobin A1c, and their objective was to achieve a uniform international A1c standardization. They wanted to make sure everyone understood A1c the same way, that they were measuring the same analyte, and that they were using it in the same way to diagnose and treat diabetes. And when this also enabled them to establish a reference method to specifically measure glycated hemoglobin for the NGSP to use as a new target standard. When they defined hemoglobin A1c, they defined it very specifically and very simply as the concentration of hemoglobin A1c divided by the concentration of A1c plus the concentration of the non-glycated hemoglobin A. This only considers the glycated and not glycated hemoglobin A. It is the proportion of hemoglobin A which is glycated. That's why it is a percent value. It specifically does not include the minor hemoglobins of hemoglobin A2, hemoglobin F, or any of the variant hemoglobins. And it is very specifically not defined as the umbrella term of glycated hemoglobin. Well, wait a minute. I thought hemoglobin A1c was glycated hemoglobin. No, hemoglobin A1c is one kind of glycated hemoglobin. Let's look at that a little more specifically. On the screen here, we see several different molecules of hemoglobin which have been glycated. We see each of the hemoglobins are made up of beta chains and alpha chains. Each of the beta chains have their N-terminal valine marked with a little circle there. And if they have a little G attached at that point, that is a hemoglobin A1c. If the G is attached anywhere else on the molecule, that is a glycated hemoglobin, but it is not hemoglobin A1c. So if we look closely at the molecules on the screen, we see that only these three on the right are actually defined as hemoglobin A1c, whereas all of these are defined as glycated hemoglobin. Now you may notice that I have specifically colored a number of the beta chains with differently than the blue indicating hemoglobin A. This is because I was a little tricky in setting this up. This is actually a sickle trait patient. And the individual molecules which have a green beta chain are designated as hemoglobin S. If you look at the hemoglobin molecule in the bottom center, you will notice that this is a hemoglobin that is glycated on the beta globin chain at the N-terminal valine, but it is not counting as hemoglobin A1c because it is that variant hemoglobin. Interestingly, some of the methods which measure hemoglobin A1c are not actually measuring specifically that analyte. Instead, they are measuring glycated hemoglobin. These are the boronate affinity methods. These methods basically have a column that the patient sample is introduced into, and any glycated hemoglobin of any type sticks to the column while the rest of the hemoglobin passes through. This enables the system to separate glycated hemoglobin from non-glycated hemoglobin. After this measurement is made, the system then has to do a conversion and convert that glycated hemoglobin number to a hemoglobin A1c number. And the trick is that it has to do it by general assumption. It is done by a simple line fit association that says if I have a certain amount of glycated hemoglobin X, some amount of it Y is going to be the hemoglobin A1c that I'm actually looking for. But I'm not measuring the A1c. I'm measuring the whole glycated hemoglobin and just assuming which part of it is hemoglobin A1c. However, in the case of a patient who has no hemoglobin A, the system is unable to tell the difference. It can't tell that it's looking at a sickle cell patient or a patient with homozygous hemoglobin E. As such, it may be reporting a hemoglobin A1c on a patient who has no hemoglobin A. Similar problems are encountered in immunoassay techniques. Now, immunoassay techniques use antibodies which are specifically targeted to the amino acid sequence at the N-terminal valine of those beta-globin chains. And we couldn't ask for anything more specific than that, right? I mean, we trust antibodies. Antibodies are organically built in order to specifically recognize these amino acid sequences. But the problem is they are only set to recognize the amino acid sequences in very specific regions. So if we are dealing with a patient who has a mutation, who has a hemoglobin variant outside of that region, the antibody can't tell the difference. In the particular antibodies on screen here, we see that the antibody in the first generation has been designed to recognize up to 10 amino acids at the tail end of the beta-globin chain. However, the mutation site for hemoglobin E is actually at the 26th amino acid. So this antibody can't tell the difference between hemoglobin A and hemoglobin E. In fact, in a later generation of these antibodies, they actually shortened the recognition sequence. So they're only looking at the last 4 amino acids on the beta-globin chain. This is missing the key 6th position on the amino acid, wherein we find the most commonly encountered hemoglobin variant, hemoglobin S, as well as it's also the mutation site for another very common hemoglobin variant, hemoglobin C. So the second generation immunoassay methods are unable to tell when they're dealing with a hemoglobin variant if it occurs outside of the recognition spot that the antibody is targeting. So if this assay was run on a patient who is homozygous for hemoglobin E, the system is unable to see that. In contrast, however, there are a number of techniques which are going to show you that you're dealing with a patient who does not have hemoglobin A. In the case on the right, we see an HPLC method. On top, we see a nice hemoglobin profile where all of the different hemoglobins have been separated out. We see we have our hemoglobin A here. We have a nice shaded hemoglobin A1c. The system is able to calculate out the values under those peaks and are able to give a nice reportable value. However, below we see a patient who is homozygous for hemoglobin E. This is a patient who has no hemoglobin A whatsoever. In this case, we see that the graph has been severely distorted. The hemoglobin A1c, of course, it's not really A1c, but the shaded peak here is being swamped by all of the other peaks around it. And clearly the pattern is grossly distorted. But the system has recognized this fact. It has realized something is drastically different about this patient, and it is refusing to give an A1c value. Similarly, we see the same thing happen in the capillary method, which also separates out all the different hemoglobins. Up top, we see a normal patient where we have a nice strong hemoglobin A peak. Out to the left, we see our little hemoglobin A1c peak. Both of the peaks are well resolved and isolated from any other peaks on the pattern. This is clearly a normal patient, and you are able to report a hemoglobin A1c value quite readily and easily and properly from this result. At the bottom, we again see a homozygous E patient. In this case, that hemoglobin A peak is completely missing, as is the A1c peak. We see an additional large peak all the way over sitting next to the hemoglobin A2. Again, clearly the system has recognized something is drastically wrong with this presentation, and it is refusing to give an A1c value. So these techniques, which present a full profile of the hemoglobins in the patient sample, are able to detect when they're dealing with patients who have no hemoglobin A in alignment with the recommendations and standards. These are not newly discovered issues with these techniques. If you go back into if you go to your current hemoglobin A1c method and you dig around in the package inserts, you will find warnings about exactly this situation that the recommendations are bringing to our attention. You'll see phrases like disease conditions such as hemoglobin SS, hemoglobin CC, or hemoglobin SC. Healthcare providers should not use the hemoglobin A1c test for these patients. Any assay which reports hemoglobin A1c in the absence of hemoglobin A are giving an erroneous result. And the manufacturers realize this. It's integral to how their method works, and they have to warn you, hey, if you have a sickle cell patient or you have a homozygous E patient, do not be putting that patient's sample on our instrument. Labs should not be reporting results if the patient does not have hemoglobin A. But how would the lab know? Very rarely does the lab have a patient's full profile in front of them that they can say, oh, well, it's not appropriate to run A1c on this patient. We've seen that there are a few techniques which give us full hemoglobin profiles and will alert us to the fact that the patient has no hemoglobin A, but what about those other techniques? Well, fortunately, the recommendations do bring to the fore situations in which you would be aware you're dealing with an abnormal patient. These represent an interference with the assay in patients without hemoglobin A. And the recommendation, it specifically states that hemoglobin A1c results below the assay lower limit or greater than 15% should be repeated, in some cases investigated further. This is an indication that patients who have no hemoglobin A have inherited double hemoglobin variants are frequently encountering clinical conditions due to their hemoglobinopathies, which result in drastically strange A1c results, result in non-physiologic results. And those kind of results coming out of your instrument should immediately be alerting you to say, hey, there's something abnormal about this patient. It's not that this patient has a 1% A1c, it's that there's something unusual about their hemoglobin that maybe we need to look closer at rather than just blindly reporting a number. A result that is outside of physiologic or analytic range may be the only indication of an interference in some assays, in those assays that can't tell when they're dealing with a hemoglobin variant. Now, you may be saying at this point, well, wait a minute, you're saying that these hemoglobin variants are messing up my A1c reporting. What about trait patients? Trait patients are much more commonly encountered than patients who have no hemoglobin A whatsoever. Are you telling me that I cannot report A1c in a patient who has sickle trait, which is a fairly common condition? Fortunately, no, I am not telling you that. Since hemoglobin A1c depends on the proportion of glycated hemoglobin A, samples who have hemoglobin A, even if there's another hemoglobin present, but if they have an amount of hemoglobin A present that can be measured and detected as A and A1c, since we're dealing with a proportion and not a concentration, we are still able to report hemoglobin A1c in those conditions. The bottom of the screen, we see two situations. The capillary result on the left is showing a patient with hemoglobin S trait. We see that the S is clearly separated from the A. The A and the A1c are sitting perfectly happy there. Nice, well-resolved peaks, easily measured, perfectly reportable. On the right, we see the same situation in an HPLC scan. The patient has a hemoglobin S peak, but it is separated from the hemoglobin A peak. They are able to calculate the area under A, able to calculate the area under A1c. This is a perfectly reportable result. Now, what about those other techniques? Well, fortunately, the NGSP has taken it upon themselves to see if there is interference caused by trait hemoglobin variants in all of the techniques used to measure hemoglobin A1c. And they have published these interference studies as well as this very handy table. And I welcome you to go online to the NGSP website and look up their interference table to check your own technique, to make sure that hemoglobin variants aren't going to be causing any interference by your technique. And as you can see here, even in assays which are unable to recognize when they're dealing with hemoglobin variants in trait patients, they are still producing results that are accurate within the tolerances defined by the NGSP. So they do not have significant interference if your patient has sickle trait or hemoglobin E trait or anything like that. But keep in mind, this is only speaking to the trait circumstance. We still cannot report hemoglobin A1c in the case of a patient who has SS disease, homozygous E disease, or is otherwise not expressing any hemoglobin A whatsoever. So the interference studies are establishing that there is no interference in trait patients. However, it is not accounting for the biological or clinical impact of the hemoglobin variant on the patient red blood cells. Well, wait a minute, what are we talking about here? I thought we were just referring to analytical interferences. What do we mean by a biological interference? Well, let's return to one of the recommendations we've already looked at and recall that we were told disorders affecting red blood cell turnover may cause spurious results, and in those cases, glucose testing should be used as an alternate. Well, what are we talking about here? Why does my red blood cell turnover affect my hemoglobin A1c? Well, let's look at an example of hemoglobin A1c formation and then see how it would be impacted by a change in red blood cell turnover. In the middle of the screen, we have our red blood cells. They're in an environment with lots of glucose in the plasma. And let's say that this is in a patient who has diabetes, whose glycemic state is uncontrolled, and as such, they are frequently in a high range of glucose in their blood. As a result, the glucose passes through the membrane into the red blood cell, adheres to the hemoglobin at that very specific spot, and we start generating A1c. Because the patient is diabetic, that hemoglobin A1c is going to be at an elevated level. But now let's consider the condition where there may be reduced red blood cell lifespan. That means some of these red blood cells are going to be prematurely removed from the circulation, and that is going to drive down our A1c level. From a nice, clearly diagnostic value here, it may even drive it all the way down into a normal range, disguising the fact that we're dealing with a patient who is diabetic simply because they have some other condition in their blood which is causing the red blood cells to turn over more rapidly. Let's look at the same topic in a different way, just in order to drive this point home. At the bottom of the screen, we have newly produced red blood cells. The newly produced red blood cell has a lifespan typically of around 120 days. After 120 days, the red blood cell membrane has been damaged enough, it has gotten enough debris attached to it, that the red blood cell gets flagged for digestion, it gets accumulated in the liver and spleen, and is broken down in order to be used and recycled into new red blood cells. During that 120 days exposure in the plasma, it is going to accumulate a certain amount of hemoglobin A1c. However, in a patient who has less time, whose red blood cells don't live as long, those red blood cells get flagged for destruction or otherwise lyse earlier than 120 days, and as a result, not as much hemoglobin A1c is going to accumulate in those red blood cells. Again, artificially, biologically suppressing the hemoglobin A1c level in a diabetic patient. One of the conditions that we haven't spoken about yet, which does precisely this, which suppresses or lowers the red blood cell lifespan, increases their turnover, is beta thalassemia. Beta thalassemia is a genetic condition in which a patient is unable to produce enough beta chains in order to meet its normal demand for red blood cell production. Similar to hemoglobin variants, some hemoglobin variants, the beta thalassemia can suppress the red blood cell lifespan, and that reduced lifespan will artificially reduce accumulation of hemoglobin A1c in the bloodstream. And this reduction may be a small amount and still have a clinically significant impact. If we assume the red blood cell lifespan of 120 days, in a diabetic patient who happens to have an A1c value of 7%, if those red blood cells, unbeknownst to us, are actually only living 110 days, that's going to suppress that A1c level down to 6.4%. That's down into the pre-diabetic range, and we are suddenly calling a diabetic patient pre-diabetic. Maybe pretty close to diabetic, but it's still making the wrong call. Now, beta thalassemia detection is a bit trickier than hemoglobin variant detection. Hemoglobin variants are at least producing some strange form of hemoglobin, which is floating around in the patient blood, just sort of sitting there ready for us to detect by any of these techniques that separate out the different hemoglobins and display them to us. Beta thalassemia isn't producing a hemoglobin variant, it is limiting the production of our normal hemoglobin. And this is usually detected only by the elevation of hemoglobin A2. Hemoglobin A2 is really only well separated on capillary hemoglobin A1c methods. We see over here that we have a hemoglobin A2 sitting well out to the right of the hemoglobin A, kind of small and isolated there, and we're going to be able to spot if that A2 value becomes grossly elevated. I need to emphasize that this is not a reportable value. In order to report an actual concentration of hemoglobin A2, you would need to run it on a hemoglobinopathy technique. But in the hemoglobin A1c, since we can see that hemoglobin A2 well separated and isolated and quantified, when it becomes grossly elevated, we're going to be able to spot that. This is not even true in the other technique, which separates out a hemoglobin profile. As we see on the screen there, the hemoglobin A2 is present, but is a little too close to hemoglobin A in order to be separated and accurately quantitated. As such, the system is not reporting even a tentative hemoglobin A2 quantification on its printout. So this recognition of patients where hemoglobin A1c is not the appropriate analyte is sort of in alignment with other recommendations in the guidelines. It is a recognition of exceptional patients, patients for whom A1c is not appropriate, or A1c might mean something a little different, or A1c goals may be a little different for these specialized patient populations. And these are things that the clinical laboratory needs to be aware of. Not every patient needs to have their A1c treated exactly the same. Elsewhere in the recommendations, we see that for a diabetic, their target hemoglobin A1c should be 7%, except in the case of pregnant diabetics, in the case of children and adolescents, in the case of elderly individuals or patients with comorbidities or particularly hypoglycemic histories. These are all special case, exceptional patients where hemoglobin A1c goals may be a little different. Specifically in pregnant diabetics, we are told in one of the new recommendations that the pregnant diabetics should be aiming for a hemoglobin A1c of less than 6%. This is likely due not only out of concern for damage to the fetus and the pregnant individual, but due to well-documented increased red blood cell turnover in pregnant diabetics, which means that A1c value is going to be suppressed. A pregnant diabetic who has an A1c of 7% is actually not as well controlled as we would like them to be, because that increased red blood cell turnover is lowering the target that we want to aim for. Moving on from talking about these special situations where hemoglobin A1c may not be the most appropriate analyte or where we need to take special consideration of it, there is another very important update between the 2011 and the 2023 standards, and that is a narrowing of the coefficient of variance that is acceptable for hemoglobin A1c testing. The CV value goals have been tightened from intralaboratory at 2% down to 1.5% variance, and from the interlaboratory from 3.5% to 2.5%, and ideally no measurable bias. This represents a significant tightening of the tolerance of scatter that we can allow on our hemoglobin A1c assays as defined by these recommendations and these guidelines. At which point, every person who is running an A1c test has to go, oh my gosh, they're tightening the standards. Is my test still good enough? Well, fortunately, there are resources that allow us to evaluate our own test and the test in general out in sort of the testing world. And that is, of course, the proficiency testing standards. Of course, is the proficiency testing. Now, all of these labs that measure hemoglobin A1c are supposed to be doing the proficiency testing and sending in their answers. And from those answers, the proficiency testing bodies are able to evaluate the CVs, the bias, the accuracy of the A1c coming out of a particular method or a particular manufacturer. You are, of course, probably familiar with CAP testing here in the US, but there are many other proficiency standards. I'm going to be talking about one called the Euro A1c studies. And I'm going to be talking about these in particular because I really like the way that they display their results. It gives an excellent summary of whether your instrument, whether your method is good enough. So in this testing, the way they display their results, or the way they have established as a method to display their results, is sort of a acceptability range. Now, please note that because this is the Euro A1c proficiency testing, that the units being used are the IFCC units in millimole per mole and the between laboratory CVs. For the NGSP values, you'll note that just below the numbers on the axis, we see the numbers for NGSP as opposed to the IFCC values. But at any rate, the Euro A1c established a device whereby they basically set up a triangle running from 5% bias in millimole per mole and 5% CV, and anything within that triangle would be considered acceptable because it has less than 5 millimole per mole CV, less than 5 millimole per mole bias. Outside of that range is considered to be unacceptable results. And to add just a little bit of an Olympic flavor to things, they've also flagged the tighter standards with different metal colors. So the assays which are able to achieve less than 3.3% millimole per mole in the CV and bias are bronze, less than 2.2 are silver medal, and down at the 1.1 values, you would get a gold medal. The Euro A1c results have been published for studies run in the years 2016 through 2022, and I believe the 2023 results are just about to be announced at ADLM. These represent many years of results, and you are able to go in and look at any particular manufacturer, any particular technique, and chart their performance in the Euro A1c results. I have taken the liberty of extracting some of the data from the site where this is available. This is publicly available data, and I've graphed two different examples here. On the left, we see a capillary manufacturer with two different instruments, and we see that these are pretty good results. They're relatively low bias and acceptable CVs. We see that they spend a lot of time in that bronze category and are even edging their way over into the silver category. On the right, we see an HPLC manufacturer with three instruments, and one of their instruments, at least, is managing to stay within the acceptability range and occasionally getting into that bronze category. But their other two instruments appear to be having a good deal of trouble sort of staying within that acceptability range and are in fact dodging outside of it quite frequently. So we recommend that you compare the recorded accuracy of your current hemoglobin A1c vendor and instrument with the expectations of these newly tightened guideline standards and recommendations. Finally, there are a couple more new additions to these standards and recommendations, to these guidelines and recommendations, which we want to speak about, but which really are not disruptive whatsoever. In the first one of which is just stating that acceptable hemoglobin A1c reporting units should be in either percent hemoglobin A1c or millimole per mole. In the US, we are typically doing percent hemoglobin A1c, whereas in Europe and in several other nations, they tend to report in millimole per mole. This is not disruptive at all. It is simply cementing a standard in place of what is already being done. Interestingly, they also speak to the concept of estimated average glucose and state that estimated average glucose may be reported in addition to percent hemoglobin A1c as an aid to patient understanding. A diabetic patient who goes into his doctor and the doctor says, "Oh, well, you've got an hemoglobin A1c of 8%. We really need to sort of tighten that up a little better." 8% may not mean anything to the typical diabetic patient because they are spending every day doing their testing and looking at their glucose meter. They're seeing where their numbers fall in the glucose meter, and that percent A1c may not mean anything in particular to them. But if you provide an estimated average glucose to the patient in addition to the A1c percent, they can look at their glucose meter and say, "Oh, yeah, actually, that is pretty high. I need to be doing a better job of regulating my insulin, of regulating my diet." So it is important, however, to note that the recommendations state the estimated average glucose should be provided in addition to the A1c percent, not instead of that value. Because again, the analyte we're actually measuring is percent A1c. So this brings us to the completion of our talk. In conclusion, we'd just like to say the latest guidelines and recommendations introduce several key concepts. These guidelines are intended to improve patient care, and they're bringing to our attention through their sort of new focus within these guidelines and recommendations that you need to account for a lot of things that may be hidden. We're talking about hemoglobin variance, red blood cell turnover, different problems like that. And that current recommendations are tightening the CV tolerances. So you need to be aware of how much sort of scatter you're seeing in your results, and if the methodologies or manufacturers have a good record of remaining within these CV tolerances. Next, note that the guidelines state hemoglobin A1c is not universal. In some cases, hemoglobin A1c is not appropriate due to analytical or biological interference, red blood cell turnover impact, and especially in cases of patients who don't have hemoglobin A. The lab should be aware of potential limitations of their hemoglobin A1c assay method and interferences within their patient population. Methods that don't detect these interferences may result in reporting percent hemoglobin A1c on patients when it is inappropriate, such as those patients without hemoglobin A. This brings our webinar to a close. Please note that if you happen to be attending ADLM in 2024, that I will be at the booth for much of the conference, and I'm more than happy to carry on this discussion, to continue it, to retouch on any of these points or carry them out to special cases, whatever your concern may be. I am more than happy to answer any questions you may have now. Thank you for your time.
Thank you so much for your excellent presentation, Dr. Wagner. It is time for our live Q&A portion of our webinar. Now, to our audience, if you haven't submitted any questions yet, please do so now. Just simply type them into the Ask a Question box, click Submit, and we will answer as many of your questions as we have time for. So, Dr. Wagner, we have some great questions that have already come in, so I'm going to just dive in. Our first question. You mentioned A1c analysis for use in patients with trait hemoglobin variants and disease state patients like SS. We don't see many variant patients in our local population. What is the prevalence?
Well, this speaks to sort of the prevalence of hemoglobinopathies, such as hemoglobin variants and thalassemias and like that in the general sort of world population. And we hear frequently from different customers, well, we don't have a very diverse population in our area. Is this really something we need to be concerned about? Um, it is clear that in some areas it's much more upfront and clear that you need to be aware of the potential of having a sickle cell patient, having a patient with homozygous hemoglobin E in your population that might be encountering these cases of sort of special cases. But don't assume that you simply have none of those in your environment. The worldwide prevalence of hemoglobin variants, I believe, is around 7%. And if you roll in like beta thalassemias, I believe that comes up to closer to 8 or 9% of the world population carry those traits or diseases in their genetics. And you really don't know. The trick is you don't know what you don't know. And a lot of labs have been surprised when they bring in a technique that can separate out hemoglobin variants, and they suddenly start discovering a handful of rare hemoglobin variants are within their population. Or hemoglobin E is one that shows up a lot and does cause trouble by some hemoglobin A1c techniques. So worldwide prevalence is somewhere between 7 and 10%. And that is a pretty profound amount of people. And even in those environments where they believe they don't really have a diverse population, they're sometimes surprised by these particular patient populations showing up once they begin to be able to see them in their testing.
Thank you. Now, I have multiple questions coming in about you mentioning capillary systems.
Mhm.
Many are not familiar with this technology. How is it different from HPLC?
Well, HPLC works sort of by a technique of retention. In HPLC, you have a column wherein you introduce the patient sample in one end and all of the hemoglobin sticks to the column. And then you slowly change the pH and salt balance of the liquid flowing through the column. And at different points, the different hemoglobins are going to detach themselves, come out of the column, and be detected. Capillary electrophoresis is directly analogous to what most people are familiar with, which is gel electrophoresis, except it's a much sharper, much more analytically clear result in which you introduce a patient sample in one end of a thin glass capillary. There's no column involved. It's just a thin glass capillary. And as the sample is carried through the capillary, the electricity that is running through the capillary is pulling to different degrees forward or backward on the hemoglobins in patient sample. And as such, different hemoglobins get separated out and emerge from the capillary at different points at the far end. So by this technique, by adjusting sort of the pH and the salt balance in capillary, they're able to separate out individual types of hemoglobins from one another, so that if there is a hemoglobin variant present, whether it be trait form or disease form, you're going to be able to see pretty clearly when it comes out the far end that it's not in the A position, or you've got a pattern with additional peaks on it or something like that. So it's directly analogous to the hemoglobinopathy screening, which can also be done by capillary or on gel. So it's kind of like, it's a little bit like a free hemoglobinopathy screen on a patient samples when you're running their A1c, because you see that separation out. Very similar for HPLC, which also separates out individual hemoglobins based on their retention sort of in the column. So both those techniques produce a full profile of sort of separated hemoglobin fractions and let you see if something unusual is present.
Thank you for that explanation. Now, can we touch on the strategies that can be employed to reduce the turnaround time for the A1c test results without compromising quality?
Okay, so really this sort of depends on the ability of the system to flag abnormal results. Um, Ideally, every single result that comes out would be reviewed by a person who looks at it and sees if it looks abnormal. But hemoglobin A1c is a high throughput test. Most labs are dealing with volumes going through their instruments that would just be overwhelming if they actually had to look at each individual graph that comes out. So the systems themselves, those that separate out the fractions, are going to be at a bit of an advantage if those systems are also able to sort of send up a red flag and say, this is an abnormal sample for review. Therefore, if you're running like 300 samples in a day, and at the end of the day, there's 12 that have to be reviewed by a person, then you've still got your high throughput. You've got a little bit of analytical time on the end, but the quality is going up, and your sort of safety factor is also going up, because you're going to see those patients where you shouldn't be reporting A1c according to the system. Now, in those systems that don't separate out fractions, they have a little bit more trouble in that there's only going to be a red flag raised if you get a value for A1c that is outside of the physiologic range or is outside of the analytical range. If you're seeing a patient sample come through with 2% hemoglobin A1c, that is almost certain that that is a sign there's something abnormal about this patient's sample. Increased red blood cell turnover, something about a hemoglobin variant that's not being detected properly, or something like that. And in those cases, that flag is going to go up, and you're going to be able to spot them. And this is sort of the reasoning a lot of times people use for like not worrying too much about sickle cell, because sickle cell has such an incredibly increased red blood cell turnover that it should bottom out that A1c value. And they use the flagging of out of physiologic range results in order to check those. So it comes down to the ability of a system to sort of spot when there is an abnormal result coming out, flag it for further review, and then depending on the lab's capability, they either notify the clinician, they look at other testing going on in the lab, they may be able to see that, oh, this is a sample that came in from a sickle cell center, we have a pretty good idea why they're getting an abnormal result, or things like that. So it is a question of laboratory workflow and sort of getting your ducks in a row. But once it's in place, that sort of extra level of security recommended by the guidelines or implied by the guidelines would then enable the lab to be more confident in their reporting without sacrificing turnaround time, quality, or safety.
So to clarify, Dr. Wagner, are these standards suggesting that all A1c results have to be reviewed individually?
Well, I spoke to that a little bit already. They nowhere in the guidelines are they saying that explicitly. They're saying that the laboratory needs to be aware of these conditions which may be affecting A1c either analytically or biologically. And it's nowhere in them are they saying that each one requires a human eye to review each result. It's saying that when the laboratory encounters something abnormal, that they don't just dismiss it and say, oh, well, this is a weird patient. This is a patient who has a hemoglobin A1c of 24%. You know, that's not a reasonable value of A1c. That's not a physiologic value. They need to be aware of the possibility of interferences in their assays so that when a completely bizarre result comes through, they are able to approach it in a fashion that recognizes there may be an interference present. They have to know that these interferences they have to be aware these interferences exist and what to move on to in order to address them, which was why the recommendations mention glucose testing, fructosamine, glycated albumin as alternates when such a condition is encountered.
So Dr. Wagner, we're having quite a few questions coming in about RBCs. How can the lab know when a patient has altered RBC turnover? Wouldn't that require additional testing that they're not authorized to do?
Yes, in order to be certain of it, yes. In order to diagnose a patient as having beta thalassemia, for example, that would require additional testing. What the recommendations are stating by stating that the lab needs to be aware of the impact of something like beta thalassemia, reducing red blood cell lifespan, and affecting sort of the interpretation of A1c. It's not saying that the person sitting at the bench has to say, that's a beta thalassemic patient. They have to say, this is a patient that has an elevated A2 beta thalassemia is suspected, and pass the word along to the clinician. The clinician, at which point maybe it says, oh yeah, we already knew about that, or oh, this explains some other things in the patient's profile. So it's not that the laboratory on its own, I mean, it's not authorized to do so, but not the laboratory on its own can't decide to run the extra testing that tells us we're dealing with a sickle cell patient, we're dealing with a homozygous E patient, but they do have to be able to sort of report either no value, because the system won't give a value in the absence of A, and say, looks like A1c is not appropriate for this patient, and tell that to the clinician so the clinician can figure out how to proceed, or say, here's an A1c value. By the way, this patient had an unusual profile indicative of a beta thalassemia or indicative of a hemoglobin variant. You may wish to confirm that this A1c is in alignment with the rest of the patient's chart. The laboratory, in doing that, the laboratory is ensuring that the A1c result they're putting out and giving to the clinician is as accurate as possible analytically, but also they're notifying the clinician that biologically there may be something a little unusual with this patient, and the clinician may wish to take that into consideration and possibly get the patient diagnosed as having a variant or having a thalassemia through ordering further testing.
Thank you, Dr. Wagner. Now, it looks like we have time for one more question, but I do want to encourage our audience that there were a lot of questions we are not able to get to due to time constraints, but they will be answered via the email address you provided at the time of registration. So Dr. Wagner will wrap with this question. How can laboratorians effectively communicate A1c test results to healthcare providers and patients?
Well, that's going to be a laboratory by laboratory sort of standards and decisions. Some systems may want to look into assigning a particular field for unusual A1c results, in that they can kind of, I always refer to it as reporting an A1c value with an asterisk, one that says, gives the clinician a warning. Here is the patient's A1c value. By the way, this patient has an abnormal hemoglobin profile or has an elevated A2 or something like that, so that the clinician is aware that yes, they're getting an A1c value, but that A1c value may not be appropriate, may not be considered along the standard sort of standard range of what's normal, what's pre-diabetic, what's diabetic, because they have something abnormal about their profile. So it's a little bit of interaction with the LIS system, with the sort of habits of reporting to the clinician. But as we sort of started the presentation with, the laboratory really needs to be concerned about the accuracy of the numbers that they're giving the clinicians in order to best diagnose and best treat diabetic patients. And when the diabetic patient is in some way abnormal or exceptional in a way that may affect that A1c, the clinician needs to be notified about that. I mean, direct comment through canned text in a field just stating, because the patient has an abnormal profile, their A1c value, this may affect the A1c value, and you should check to be certain that it is in alignment with the rest of their glycemic information. Sort of canned text stuff goes a long way towards notifying the clinicians appropriately.
Dr. Wagner, thank you so much for this detailed Q&A session. Now, do you have any final comments for our audience?
I think we've covered just about everything. Just take a good long look at your current A1c methodology of choice. Realize that the focus of the standards is sort of shifting to account for the fact that we're dealing with specialized patients. It's all sort of a movement towards individualized medicine that looks at particular patients and particular environments. And some of these patients are going to be falling into groups that are sort of profoundly different in how A1c shows up in their system. And you're going to want to be certain that with your A1c method of choice, you're able to spot when you're dealing with one of these particular patients. The clinical lab isn't going to be able to go through and search the chart of every patient who gets an A1c ordered on them to determine when those patients are special. So keep all of this in mind as you review your A1c results, and what you can sort of pass through to the clinician, and what maybe you need to take a minute and look closer at to sort of figure out what's going on. I think that handles the main points that we discussed today.
It certainly does. Dr. Matthew Wagner, thank you so much again for your time today and your important contributions to best practices of HbA1c for the clinical library. Clinical laboratory. I do also want to thank LabRoots and our sponsor, Sebia, for today's educational webcast. And also, before we go, I do want to thank our audience for joining us today and for their interesting questions. As I mentioned previously, there were quite a few questions we were unable to get to. And then additionally, those that are submitted during the on-demand period, they will be addressed by our speaker via the email address you provided at the time of registration. Today's webcast can be viewed on demand, and LabRoots will alert you via email when it's available for replay. Please share that email with your colleagues and your friends who may have missed today's live event. Thank you for joining us, friends. Hope you have an excellent day. Bye for now.